advocates, and I'm going to talk a little bit about just give some very basic information about New York's Medicaid managed care program and Medicaid redesign, which is an initiative that's sweeping through the state really fast and making some very, very big changes in our Medicaid and Medicaid managed care system on a very, very short timeline. So I'm going to speak about those changes briefly and some problems I've seen in my practice with managed care generally, and then kind of talk about how we might be able to, or we're all going to talk about how we might be able to move towards a different model. So in New York, today. I forget my glasses and I forget to talk. So in New York's Medicaid program, there's two basic models. It's the Medicaid managed care model and the fee-for-service model. Again, this is really basic information. Medicaid managed care is that the state pays a capitated monthly rate per member to a private plan to provide almost all Medicaid services through that health plan. In New York State, one of our big problems, especially with our disabled enrollees, was the carve-outs. Some of the services were provided through the state benefit card still, and some were not. So if you didn't understand that bifurcated system, it was quite hard for you to access care. In managed care, enrollees must follow plan rules in order to get care. You have to choose a PCP, receive in-network treatment, obtain referrals, prior authorization, all of those kind of things that can be seen as hurdles to care. So, kind of a history of Medicaid managed care in the state. Mandatory enrollment began for single adults and families, so the non-disabled, in '99. SSI recipients, so people who were in receipt of supplemental security income or certified disabled, began being mandated into managed care in 2005, and that means that they had no choice. They had to be in Medicaid managed care unless they had a really good reason called an exemption or an exclusion in order to get out. Mandatory enrollment of SSI recipients with serious and persistent mental illness and serious emotional disturbance began in 2007. This is where I saw the most complaints about access to care in my practice, and mandatory enrollment of people living with HIV and AIDS began in September of 2010. There are 3 million Medicaid managed care enrollees statewide, 31 plans, 10 for-profit plans. So Medicaid redesign is the Medicaid redesign generally is an initiative of Governor Cuomo. He appointed the Medicaid redesign team, and they were challenged with reducing costs and increasing efficiency in the state Medicaid program. The Medicaid redesign team's recommendations were incorporated into the state budget last year, and one of the results of Medicaid redesign, along with really just kind of an overhaul of our Medicaid program generally, is that almost all non-duals currently not enrolled in managed care will have to enroll over the next 2 years. So this is, you know, besides the disabled populations that I just spoke to in that went in 2005, 2007, 2010. Now this is some other populations that are severely disabled, and we'll go kind of run the gamut from people living with HIV and AIDS statewide to nursing home residents, foster care children, waiver recipients, so Medicaid waiver recipients, so it's some severely disabled populations. So, as I said, the effect on Medicaid is mandatory managed care for almost all through the elimination of many exemptions and exclusions from mandatory enrollment in a health plan, special plan enrollment of specific populations. So, for example, duals who require more than 120 days of community-based long-term care are very soon going to be forced into managed long-term care models this summer, if the state receives approval from the feds. One of the other effects is the streamlining of the mandatory enrollment process. It used to be that if you were disabled, you had a longer time to choose Now you have a very short time to choose a plan, which is hard for people with lots of different providers, frankly, because you have to make a very important decision in a very short time. New Medicaid applicants have to choose even at application, which gives you really no time to make an informed decision about who what plan you want to be in according to who your providers are. A Medicaid redesign also increases the number of services included in the Medicaid managed care benefit package. There used to be a whole lot of carve-outs, meaning you still use your benefit card, your fee-for-service Medicaid to get care. Those carve-outs are being eliminated. So now home care services are provided through Medicaid managed care plans. Pharmacy benefits are provided through Medicaid managed care plans, and soon skilled nursing facility services and nursing home services will be provided through the benefit package. These are services that managed care plans didn't want. They're kind of being forced to have to pay for them now. Also, there's a lot of different payment reform and kind of payment methodology, rate scaling reforms that I'm not so familiar with because really I run a helpline, and when I was in the legal services world, I ran a helpline just to get Medicaid consumers what they need, so I'm a little bit, this stuff I'm a little bit less familiar with. But there are lots of different program cuts, like just basic caps and limits on services. For example, OTPT limits, speech limits, enteral formula limitations. Okay, so these are the new mandatory populations that are going in very soon, and this is quite specific, but basically it's people with some very serious needs, like homeless persons, foster care children, restricted recipients, waiver lookalikes, with the exception of people in the OPWDD system, which is the Office for People with Developmental Disabilities, residents of residential treatment facilities and people with similar needs, people with serious and persistent mental illness or serious emotional disturbance that are not on SSI. All these different categories of people who used to not have to join a plan because they had a barrier, a specific barrier to care, like a language barrier, a geographic barrier. They were with a specialist or a primary care physician who didn't take any managed care plan. And so the theory was, we don't want to disturb your care. Now that theory's out the window with MRT. These are the ones that will remain. Folks with chronic conditions who are in active treatment with a specialist who does not participate in any Medicaid management plan. This one has now limited duration of 6 months. Medicare recipients, Native Americans, people with other comprehensive insurance, and people with limited Medicaid benefits, like spend-down clients, people who only have emergency Medicaid, and the like. The Medicare, the people who are duals on Medicaid and Medicare, there's a demonstration program that's coming down the pike in the end of the week, actually, that will seek to mandatorily enroll even duals and duals with long-term care needs, waiver duals, duals with lots of different service needs. So this has not, having Medicare is not going to stop this train so far, at least in terms of the State Department of Health's eyes. And special enrollment of specific populations. People living with HIV and AIDS are allowed to choose special needs plans or mainstream plans. I spoke about this a bit, managed long-term care models for duals. And behavioral health organizations are being created now before full integration of behavioral health services into managed care, and some other special models for people with serious and persistent mental illness. Behavioral health services is a carve-out for people who are certified disabled now. That means you use your regular benefit card, and this has been just a huge issue, and I'll talk about it in the most important slide, which is coming up. These are the current carved-in benefits under MRT, which I spoke about a bit. All these services used to be carved out and are now carved in or soon will be carved in. And I spoke about streamlined enrollment. Another piece here that I left out is that you get locked into a managed care plan here in New York if you don't switch in the first 90 days. You can't switch thereafter.
Permanently?
Until a year. Until you've been in for a year. Or you have other good cause, and the reasons for other good cause are smaller and smaller and smaller and smaller every time you look at them. So these are the past problems that I've experienced. So I'm going to just speak a little bit quickly about my experience in 2007. I was working for legal aid at the time, and I got this is when our state started mandatory enrollment for people with SSI that were seriously and persistently mentally ill and seriously emotionally disturbed. We got dozens and dozens and dozens of calls from moms of children with different, on the spectrum, different kinds of developmental or physical disabilities, maybe not necessarily on the spectrum because some physically disabled, that were having trouble accessing their home care provider because, why? Because they were magically enrolled into a plan. The way that our mandatory process works is that if you don't choose a plan, you're kind of default enrolled into a plan. So mom wouldn't get mail, mom is overwhelmed because her kid is disabled, you know, any number of reasons why Medicaid recipients don't respond to mail. Mom doesn't know, kid doesn't know, provider doesn't know, and kid is auto-assigned to a random plan that none of their providers participate in. So the 30th of the month, they're going strong, they have their home attendant and everything is fine, they have their home health aide, and the first of the following month, their home care agency says, I'm sorry, we're not sending anyone today because it turns out that you're in Health First and we don't accept Health First. And we swiped your card today and it turns out that you've been in Health First for months and we just realized it because we haven't swiped your card in 3 months. And so mom is saying, I'm going to have to go to the hospital with my kid if the home health aide doesn't come today. So one of the huge problems was outreach to recipients and training of providers. I know we're in a provider room, but you know, we had just dozens and dozens of cases where providers didn't understand transitional care rules, didn't understand that they could bill for out-of-network services, were unwilling to do so, even when a plan was willing to pay, which is far and few between. So the issues were how do we make Medicaid recipients understand better what the model is, what's being pushed on them, how to access care in it. Second, how do we train providers to make them aware that this change is happening to the people that they serve every single day? I mean, it seems completely outrageous to anyone, probably you or me, anyone in this room, that providers that are normally providers of hundreds of Medicaid recipients with disabilities wouldn't know that a particular sweeping change that's going to affect thousands of people is going to happen in terms of their billing systems and in terms of the care they give. And then transitional care benefits for new enrollees. This is something that's in our public health law. When you join a new managed care plan, you have a chronic or disabling condition, you're allowed to get transitional care for up to 90 days or until a new plan of care that's in-network is put in place by your managed care plan. Plans didn't know about this, providers didn't know about it, consumers didn't know about it. Also, as many of you might know, if you're a provider that's not participating in a specific network, you don't know how to bill a network that you're not part of, right? I mean, it's just, that's just it. You wouldn't know how, just like if you go to a new grocery store, that you've been going to the same grocery store for 20 years, you don't know where the milk is at the new grocery store, right? So that was a really big problem, was just getting providers to, to understand how to bill and getting plans to work with those out-of-network providers. And then access to specialized services. This one that I had the most experience was the home care services, specifically home health aid services, which is, for someone who has skilled need a little bit of a higher level of care. Access to durable medical equipment and supplies. And these have a lot to do with the carve-outs. People also were, in relation to this, confused about which of their plan cards to use. And providers were confused about which of their plan cards to bid. Non-emergency transportation, and then network adequacy, which is always a biggie in managed care. Just, these are my specialists. How do I either choose between them to join one plan or, you know, how do I gain access to other specialists in this field that are going to be able to care for me. The accuracy of information on these HMOs' websites is very, very poor. The accuracy of information, even that the enrollment broker that we have here in New York, their system hits up against the state system for what provider is in what plan, and frankly, the information is dated. The state can't figure out how to make that information more up to date. So kind of that information is really lacking. And then on the notice issue, we have had a lot of problems with clients receiving a notice, because if a provider doesn't actually request the prior authorization, but has had, you know, historically a specific plan won't pay for a specific treatment for a Medicaid beneficiary, they're going to say, you know what, your Medicaid plan doesn't cover this. And so then if the provider actually doesn't request a service, it does not generate a notice to the Medicaid beneficiary, so they don't know that they have rights to appeal, fair hearing rights, and the like. And so we've seen a lot of those types of notice issues where plans don't issue them. And again, the bifurcated system of mental health benefits being a carved out for most recipients was really an issue in terms of access to care. So this is just a little bit about, you know, the problems I've seen. Now, after 2007, we did some advocacy around the impending rollout of people living with HIV and AIDS. We got them to push back their rollout by a couple of years. We got them to push back mandatory enrollment in one borough, Staten Island, because of the lack of a special needs plan there. So we did buy ourselves some kind of time there. And that rollout, as far as I'm concerned, went a lot better. I got, you know, if I'm going to tell you hundreds of complaints regarding the 2007 disabled population that went mandatory, I think I probably got 2 or 3 about the enrollment of people living with HIV and AIDS, and they were in regards to marketing. And, you know, there's a handful of complaints about the carve-ins, the recent carve-ins that I've received. But I think that generally the state got our message that their outreach and training, just as an initial matter, sucked. And had to be, kind of that piece had to be overhauled. They have to work in every day looks like. So I, you know, the state has kind of made some headway there, I think, since the enrollment of the populations more recently. And we're monitoring how they are going to do for these populations that are going to be newly enrolled after Medicaid redesign. And the specific populations that we're keeping our eye on now are homeless people who are slated to be mandatorily enrolled April 1st. So I guess we're going to give it back to Len, unless anybody has any questions.